So you announced DocGraph at Strata RX last fall. Can you explain what that is and where the project stands?
Well, I'd like to answer that question from the just general Strata perspective as opposed to Strata RX perspective. At Strata RX, I was talking about how it's a database of the social graph of how hospitals and doctors work together to deliver healthcare in the United States. I think but that's when you're talking about Strata RX, which is specific to healthcare. Now that I'm at Strata, I want to say this is the largest named graph database that has real names, that's out in the open, that you can look at all of it. Of course, Facebook, LinkedIn, Twitter, all of these companies have much larger graphs about social relationships, but none of them are entirely out in the open. They spoon feed it to you. They consider it really their most valuable intellectual property. And well, they should. So we think this is the largest graph database of any kind that uses real names and shows relationships between how people work together. So we're pretty excited about that, and we're hoping to convince more people here at Strata to participate in analyzing this data.
What types of relationships does it show?
So the very specific answer to that question is it shows when two providers or a hospital and a provider or any people who work on a patient work on a given patient at the same period of time. So let's say that we were both doctors and we had a patient. If you worked on that same patient within 30 days of me working on it, and we both billed Medicare for that, and we did it past a certain point, so we have to do that 11 times in a year in order to protect patient privacy, then it'll show up as essentially a 1 in my data set. And obviously, if we've got 1,000 times that's happened, that's very interesting. We've got a very strong relationship. Most of the time, that's going to be a referral relationship. So I might be a primary care and you might be a cardiologist, but there's all kinds of other teaming relationships that are going to be shown. So for instance, you might be a lab provider, or you might be a hospital, or you might be the attending physician, and I might be a resident. So there's all kinds of different relationships that the data shows. And in fact, that's exactly the question that I want the Strata community to help me answer.
So a while back you wrote, I'm going to read from this here, this is quote, "I believe that the only way to solve the problems in healthcare is to embrace a radical openness with health data." What does radical openness involve, and who is that going to anger?
Well, I mean, I think it should anger and make almost everybody uncomfortable. The problem is that as I think about myself as a patient, I eat too much. Thankfully I don't smoke or use hard drugs. Really simple carbohydrates are my drug of choice. So simple sugars. We need to understand as patients that when we eat ourselves to death, that's something we need to be accountable for. And ultimately, open data is going to make patients uncomfortable. The data that I'm releasing makes physicians extraordinarily uncomfortable. They have business relationships and contracts that now it's public information about whether or not they're adhering to those contracts. Teaming relationships, you can tell whether or not someone is participating in a hospital network and these kinds of things. And that's the data that I've released. But in general, healthcare is made up of these organizations that do a lot of finger pointing. So the federal government, patients, insurance companies, drug companies, all of these organizations believe wholeheartedly that if the other organizations and the other groups in healthcare would just get their act together, everything would be okay. And that's just not realistic. And so I think the answer to how you start to balance interests between physicians and patients, between drug companies and physicians, or drug companies and patients, between the government and insurance companies, is to have data that is, deeply relevant. And I think the easiest way to determine whether or not something is deeply relevant is to decide whether or not it makes someone uncomfortable.
Okay, so last question, it ties into this a little bit, because I'm interested in knowing, it's actually twofold. One, let's say that we go through this period of uncomfortable radical openness. What does that look like after we're through it? And then two, what's the relationship between data and healthcare like 5 years from now?
I mean, I think the answer is the same. It's really two different versions of the same question, and the question is, what road are we on?
Mm-hmm.
Where does this yellow brick road lead? And it's very hard to have any kind of definitive answer. But I think there are elements that we can't predict. So an element that we can easily see coming is that we're going to have accountability, and I think the word accountability appears in all kinds of legislation. We can't have accountability without data, and so we're going to start measuring things that we haven't measured before. There's going to be cases where And really, it's only a question of, it's not whether or not we're going to have upheaval, it's how much upheaval we're going to have. We know that the cost structure doesn't work. We know that we were spending way too much money. I'm wondering if hospitals will be around in 5 years as a class of entity. I think other classes of entities might take over as the primary class, because hospitals are so large and expensive that they become almost unmanageable. And so we might need to split them up into something that is manageable from a data perspective. So I really don't know the answer to that question, except to say that things are going to be very, very different, and that in general, we're going to be leading whatever reform movement there is going to be data driven.
Great. Well, thanks so much for being with us.
Thank you very much.